So today, everyone, you have a very special lecture from Dr. Ben from UC San Francisco. And he's also, as you know, the person, the mind behind all of Rayos Contra cancer. So it's very, very cool that he's going to be lecturing for you guys today. So I'm going to hand over the microphone to him. And as always, feel free to type your questions into the chat box or to raise your hand if you want to ask questions. Today's going to be kind of interactive, and Dr. Ben is going to be giving an overview of ProKnow, which is a really nice software that's free for you guys to use and will help you with practicing contouring in the future. So without further ado, I'll let Ben take it away.
Okay, great. Thank you so much, Tia, for the kind introduction and welcome. This is actually my first time ever giving educational session. Usually I'm just helping to moderate the sessions, but I'm very excited to help teach, so hopefully some things, but mostly to show you things that other people have made that can be helpful. So we assigned a task for this week to upload a case to ProKnow. ProKnow is a cloud-based system that will let our clinics to share de-identified radiation cases for learning feedback and education. It also allows us to establish objective measurements and really translate the knowledge into improvements in practice, and this is our dream. So ProKnow works across all imaging, planning, and treatment modalities, regardless of the vendor you work with, the machine or the treatment planning system you have. And I hope that this can be the first step. Hopefully you can gain experience and ease using this, because I think that we all can benefit from this platform if we use it together. So it's a little bit like our secret weapon. And so I'm now going to show how you log in. You should have gotten the instructions, but you follow this link. You'll log into ProKnow. You also have received your username and password to log in. You'll see a screen, and here you can upload cases. Uploading a case is as simple as selecting the file on your computer, but you can ask your medical physicist to help you in exporting the file so that you can load it. And then once it's loaded, you should see the progress bar. And then you'll see the patient that you loaded. You can change the patient name simply by double-clicking on it. Then in the top right screen, you'll click Actions, Edit, and you can choose the name. And then here's what it looks like when we're actually looking at a case. So all of that was just kind of how we get to this step. You'll see that there are 4 kinds of files. One is the CT scan. One is the structure file that contains the contours. The third is the plan file that contains information about the plan that you're using, what energy, how many beam angles, or how many arcs, what the MUs are. And then the dose, so you can see what the dose distribution looks like. And here I'm going to show kind of some examples that we've had from some of the centers. And before I get into that, I just want to say this is the first of a couple homework assignments. But once you get used to this, the medical physicist will then be able to use ProKnow to practice planning or to apply planning concepts. If the TPS isn't commissioned yet, we'll have written assignments. And then we'll provide feedback on the plans that you make or whatever you turn in. And for the radiation oncologist, we can use ProKnow to practice contouring, which I hope will be really helpful. All of this is in this document, which your clinic coordinator should have. So let's see where the fun begins. So here, I just went to rcc.proknow.com. And then it asked me to log in. You should have your own login information. And we can see some of the clinics have uploaded some cases. So this is very exciting. Congratulations. Thank you everyone for preparing in advance. Let's focus on this case. This is a rectal cancer case. As you can see, it's planned with sort of two beams. So you have your opposing laterals, and then presumably this is a PA beam entering from the back and going to the front. And you can see the dose distribution and it tells you the dose here. If you want to know what plan this was, you can see this was 23 fractions. And then there was a boost delivered just to sort of the highest risk disease. And then you can click on the plan and see, okay, this was a 2-fraction boost. So in total, this patient got 25 fractions. And this is a sort of advanced trick, but I'm going to show how we can actually create a composite dose. So I'm simply going to add the doses. Again, I selected, so first I clicked edit, then I selected the doses I want to add, and then click composite. And I'll call this composite dose. And now we have a composite dose. And we can see here that in fact our high-risk disease was treated to a total dose of, looks like around 50, somewhere between 50 and 53 gray, which is what we would expect for a rectal cancer case. Now, let's review some of the concepts that we've gone over so far in this course regarding contouring. So I'm going to pull this up on the side. This is a refresher from Dr. Shada's lecture, where she talked about GTV, CTV, and PTV. So here we can see it in action. I'm going to zoom in just a little bit. And so this is a rectal tumor, and we'll start with the gross tumor volume. Hopefully you can see both of these things. Okay, very good. So this red structure is the gross tumor, basically what they saw with their eyes as they were looking at this case. And you can see that there's a solid tumor here. So it's evident. Sometimes these cases are hard to see the gross tumor on a CT scan because the bowel and the mucosa kind of blends in and things look really similar. So actually a sigmoidoscopy is very helpful to know exactly how many centimeters from the anal verge is the tumor. So when I'm contouring this, I'm not just using the scan that I see, but I'm also using the other information that's available to me. So physical exam for certain tumors, in this case, the endoscopy report, I would review that and see what distance it was present and how it appeared. And then I can measure on the sagittal view from the anal verge just how far up this was. Any questions about this so far? This is the GTV. Next, we have the CTV, which is the clinical target volume. And you can see that it includes space around the GTV, where we think there could be microscopic spread of disease, as well as the lymph nodes, which we think are at risk of harboring a microscopic tumor. And we know that, if we only treated this gross disease here, there's a high chance that the patient would come back with recurrence in areas where there's high risk of having microscopic disease, in this case in the internal iliac lymph nodes, but also lymph nodes within the mesorectum and the presacral space, and even higher up to the bifurcation of the common iliacs. So CTV covers anywhere we expect there to be gross or microscopic disease. It's not just a uniform expansion. Any questions about CTV? The CTV will be different depending on each disease site. It will also be different depending on the stage of the disease. In this case, for a rectal tumor, we have a certain patterns of lymph nodes that we cover, and this depends on sort of the expected drainage. If this tumor were to invade posteriorly into, let's say in males, the prostate or the prostatic urethra, now we know that there's risk of more anterior extension, and we would actually cover the external iliacs also to cover the lymph node disease that might be present there. And if this were to extend down and have anal involvement or near the dentate line inferiorly, then we know that there's a new channel of lymph nodes that drain there, and those would be the inguinal lymph nodes. And you want to make sure you cover the inguinal lymph nodes for that. So I'll get more into how do we know what to cover for the CTV, but this is the concept of the CTV. And lastly, we have the PTV. Now, look at the sagittal view, look at the coronal view, and then look at the axial view. And you can see that the CTV looks like just a uniform expansion. And oftentimes the PTV looks like a uniform expansion. And so the PTV, or the planning tumor volume, is a geometric expansion that accounts for small variations in patient positioning and any expected mechanical inaccuracies of the treatment system. I wouldn't think of the PTV as error, because this is rather its variability that we anticipate. So it's safety. And ultimately, our goal is to treat and prescribe to the PTV. Now, these are all targets. Now let's look at some examples of organs at risk. So here in the pelvis, one of our principal organs at risk is the bladder. And you can see that's driven here. We also have our femoral heads, which are shown here. And one important concept is if you don't measure what you do, how can you tell if you're doing something right, or how can you tell if you're improving? And also, you do not see what you do not draw. So if we look at the DVH, so remember we had our dose. The DVH is going to show us what dose are the structures getting that we drew. And in this case, we can see in the orange line is the DVH curve for our bladder. And we can see here on the left that the maximum dose was 49.7 gray. The average dose was 39.8 gray. And our bladder was drawn to be 20.2 cc's. Now, I'm going to do an experiment. We're going to take a picture of this DVH. And now, what happens if I change the structure? So going back here, I see the bladder. And let's say I'm being friendly and I'm peer reviewing this. Maybe I'm a colleague in the center and I'm just making sure that everything looks good. I might look at this and say, well, I think some of this is actually also bladder. So I want to make sure that we're not missing this. So I'm going to cover this, make sure we're not missing any of the bladder, even the tip. Good. So now I think I have the bladder more completely covered. I'm checking it, it's going down, making sure this looks good. And you know what, actually, I would count this as bladder also. Okay. So now let's let's see, I will commit this. And if I go to my DBH now, remember last time I said that the bladder was 20.2 cc's. It's calculating the DBH data. But what do people expect? Are we going to have different average dose and different max doses now? Well, here we see that the bladder now is actually 32.8 cc's. The max dose is 50, and the mean dose is 40.7. And I think last time the mean dose was maybe 38 or 39. And if we look at these two next to each other, we can see that they're similar. This was before, and this is after. But actually, you can see that more of the bladder is getting more dose now here. It's a little subtle, and I wish I could overlap this exactly, but hopefully you can appreciate that the DBH has changed because my contour has changed. And this is just to illustrate the point that if you don't contour exactly how the anatomy is, your DBH may give you a false sense of security. Maybe you set a certain constraint and you thought that you had met it, that you were just, one gray below your goal, but now actually you're 1 gray above your goal. So these subtle differences are important, and I just wanted to show this as an example. This is important for OARs because this will help us to prevent toxicities, and it's especially important for targets because for targets, we often play a really fine line between prescribing just enough dose, or if our calculations are wrong, if our contouring is wrong, then we're prescribing just below the dose that we need. And I just wanted to point out that you have to draw everything if you want to treat it. This includes any gross lymph nodes that could be present, and sometimes they're easy to sneak under our radar. But if there's a grossly involved lymph node and it's not contoured, it's probably not going to get the full dose that it needs. And the cancer is likely not to be fully treated there. And so we went through all of this effort. We really raised hopes and expectations, and the patient thought that they were getting the best. But if we forget that lymph node, the cancer could all come back. And now you're in a hard situation because you have to think about retreating the patient or figuring out what you can do. And so really we're a field that focuses on precision, and there's a lot to be proud about for that. But it can also be very dangerous. So we have to make sure that we're being as responsible as we can.
Then we have a very important question, I think. So Dr. Beestoon is asking about defining the CTV from the GTV. And in the case of, for example, the same disease like a rectal cancer with bulky pelvic lymph nodes, should you give the same CTV expansion to both of those sites? Or how do you as a clinician decide on how big to make the CTV expansions?
So Dr. Beestoon, I'll get more into this later on in the lecture. To answer your question quickly though, where you see gross disease, where you might see like a really bulky involved lymph node, you'd want to contour that also as part of the GTV. And then you'd want to include some sort of expansion around that to account for the microscopic disease that could be present in the vicinity. You also want to make sure you're covering your standard CTV volumes, covering all the lymph node areas that you might expect disease, whether or not there was a gross lymph node there. And then you would add those CTVs to get your fully representative CTV. Tia points out a good point that the CTV, if you're expanding from the gross area, Usually we don't include bone and we don't include muscle because those have hard planes, and usually the tumor has a hard time penetrating those planes. And unless you see the tumor really involving inside the bone or inside the muscle, we don't include that in the CTV for a soft tissue disease. Good. So I'll answer the question more as we get later on here at Dr. Vistun. I'm going to make the screen big again. So on the topic of OARs, we just saw one case and we saw some of the OARs they included. There may be some other OARs which I would include. And really, which OARs you include depends on what site you're treating and what OARs are in the treatment field that you're performing. So oftentimes there's a list of OARs that will always be present for certain diseases. And I find it very helpful to actually create templates of these lists for when you are writing your planning directives or your planning instructions for the physicist to list the OARs that are important for that site. So it's always there every single time. And by reducing the variability in what we do, we will become safer in our practice. Also, we're all human. It's very human to make mistakes. So we know in many other domains of medicine, it is essential to include checklists. And so think of this as a safety checklist that we have to make sure that we never forget. We also want to include what our dose goals are for these OARs. So for instance, for prostate cancer, every case should include the bladder, the rectum, large bowel, small bowel, femoral heads, and the penile bulb. And for post-mastectomy breast cancer case, every case should have the heart, the trachea, the left lung, the right lung, both lungs combined, and the spinal cord. And we should include in our template space and flexibility to add additional structures as needed, because every patient's case might be unique. Remember to use consistent and standard nomenclature when you're putting these in your planning system. So when you're labeling the name of your contour, I recommend using the Tg263 nomenclature. So large bowel would always be written as bowel underscore large, and small bowel will be written as bowel underscore small. And kidneys would be written as kidney underscore L for left and kidney underscore R for right. And if, as a center, from the very beginning, you use the exact same names, it'll help you so much in the long run. It'll help you for when you're doing your plan reviews. If you ever want to do research and collect data and measure it, it'll save you so much time of having to figure out, matching different names. And it'll, especially as we get into big data analysis and, we want to be thinking about possibilities of machine learning and artificial intelligence in the future at our centers. If you have years and years of data of all the exact same names, it'll be really easy to implement those. So I've provided links here where you can visit and download the names that they have, and you can use those. I just wanted to reiterate again something that Shada shared, that she suggests creating teams for each disease site and really thinking about the protocols and as well as other factors like the slice of your CT cuts that you will do for those cases, the mobilization that you'll do for those cases, and the type of image modalities, etc. Okay, do people remember what this is? So I've gone ahead and actually just included everything. That way, when you have this presentation, you'll have all of this. These are the Quantec Guidelines, Quantitative Analysis of Normal Tissue Effects in Clinic. These guidelines were established in 2010, and a way for us to have basically a guide for all of our OARs. What dose constraints should we use or should we consider using? Here it'll tell you what organ you're focused on, so this would be the brain. This is saying what the treatment type is for these guidelines. This is 3D conformal, so perfect, that's where we're at. This is the toxicity that you're trying to avoid. So they want to avoid brain necrosis. And here are the parameters that they recommend achieving when you do your plan. So keep the maximum dose, or the Dmax, less than 60. If you keep your Dmax less than 60, on average, you'll have a less than 3% rate of brain necrosis. It sort of shows you how this rate changes if you have different Dmaxes. They've carefully created this for many different disease sites. So when you meet as a team and decide what goals do I want to have for each disease site, I'd recommend referring to the Quantec Guidelines to help you establish which parameters you want to use for each OAR. And you might be asking, how do they know? So I investigated this a little bit, and because I was also curious, like, where did this come from? So actually in October of 2007, there was a workshop with 57 invited participants from North America and Europe here in Wisconsin. And they each divided up into working groups to develop organ site-specific guidelines of the quantitative dose volume relationships. They reviewed all the available literature that they could find on studies that were published, usually high-quality prospective studies where we remove the bias and we're able to just see the raw outcomes and toxicity profiles. And 3 years later, they published what you see now. So is it perfect? No. But it's generally regarded as clinically acceptable. Any of the really dangerous side effects are kept to pretty low rates if you follow these guidelines. And there might be mild effects that happen more commonly, but clinically that's okay. Our main goal is to treat the target fully, because we know that if you have a marginal miss, this can be more serious than any normal tissue complication that you would get. Because for many, recurrences are difficult to manage, cause severe morbidity, and usually result in mortality, especially in countries where it's hard for patients to come and get seen a second time. So generally, you should prioritize target coverage over the normal tissue risks, but there's a way to strike that balance of getting good target coverage, but also being safe and avoiding dangerous toxicities. Okay. So I just showed an example of a contour and why the quality of the contouring matters, because even small changes in volume can have relatively big changes in what our DBH looks like. And there are two recent studies which actually illustrate this, I think, quite well. One, which some of you may be familiar with, was the UK Fast Forward trial for breast cancer. They had 3 arms trying to compare new hyperfractionated regimens, which is kind of very interesting in the time of COVID. And so they looked at 40 gray and 15 fractions versus 26 gray and 5 fractions versus 27 grays and 5 fractions. There's only 1 gray difference here. But in the UK, they really like to test the limits. And you can see 27 gray versus 40 gray had higher risk for normal tissue toxicities. But 26 gray versus 40 gray had no difference. It's only 1 gray difference, but it was statistically significant. And I think this illustrates that, even 1 gray of dose can make the difference. In rectal cancer, there was the OPRA trial, which is looking at, can we do a watch and wait approach? So instead of always performing neoadjuvant treatment and then going to surgery, they found that by adding about 3 or 4 grays of dose, that they're now able to safely watch and wait many, many patients. So, normally we treat to 50.4 gray. By just adding 2 fractions to get it to 54 gray, suddenly these patients are just able to avoid surgery in maybe more than half the time. So this to me was remarkable. I never thought that 2 fractions could make that much of a difference. But like I said, really we practice right on the edge. Our doses are designed to be safe and effective, but there's little room for error. So if we really want to practice the cutting edge techniques and the cutting edge doses, we have to do it with cutting edge accuracy. It doesn't mean we need cutting edge technology, but it means that we need to be as accurate as possible with the technology that we do have. I think that as radiation oncologists and medical physicists and professionals, this is really our responsibility to the patients. They really trust us to do what's going to help them. And these little tests that we do, 1% threshold accuracy for some of our QA, the contour has to be, just a little bit right. All of these things add up. And if we're sloppy here and sloppy here and sloppy here, at the end, we don't know actually what we've delivered. So getting to Dr. Bistoon's question, which I'm sure many other people had, how do we know what to draw in what situation? As I mentioned, for the GTV, you have the physical exam, you have endoscopy reports, you have your imaging, CT, ultrasound, PET, MRI. You also have your prior imaging. So go back and look for those liver metastases or for those lung metastases. Which ones are old? Which ones are new? Which ones are growing? How did the imaging look before chemotherapy? Or how did the imaging look before surgery? These are all things that you want to consider when you're making your GTV and your CTV. For the CTV, let's say it's a case where the gross tumor was removed. So you don't see a GTV. How do you know what to draw? Look at the surgical reports. The surgeon might comment on where was the tumor touching? Were there any structures they saw that were involved? You want to make sure that you cover some of those with the CTV. Look at the pre-op imaging. And in all cases, we should use contouring guidelines. So for those of us that are just getting new into contouring, it's tricky. There's a lot to learn, but these guides can really help you. And if you start with these guides, you will learn the best practices from day one. Then you will practice and this will become normal for you. And so you will have good habits. So I'm going to share some contouring guidelines, but let's understand what goes into a contouring guideline. So in our field, we've done lots of studies. These studies helped us establish what the outcomes are for radiotherapy, what the efficacy is. And now we see the patient in front of us. It's how we know that radiation is going to help them, and it's indicated. And these studies, that they had to develop protocols for their studies. And so they have to agree, how are we going to treat someone? Everyone's going to follow the same protocol. And how are those protocols developed? Well, they're based on our experience, the best knowledge that we know. And a lot of times, this is kind of interesting, we borrow experience from surgery. So for rectal cancer, why do we use a 2-centimeter inferior margin for our CTV? Well, it's because when they did surgeries and they would remove gross tumor and also an area around it, they saw that there was kind of within those first 2 centimeters where you would find the microscopic disease. So now it makes sense. We can apply this for radiation if we're radiating an intact tumor, where might we expect the microscopic disease to exist? Well, let's borrow based on where we found for our surgery. Same for prostate. How do we know how much of the proximal seminal vesicles to include? Well, we look at our reports that we've had over the years for surgery, and we kind of find, within that first 1 to 2 centimeters of the seminal vesicles is where you might find microscopic prostate cancer. We also use concepts, and in this case, lymph node drainage patterns, especially important for head and neck cases, but also for diseases in the pelvic, in the thorax, and in the GI system. And understanding the drainage pathways and being able to anticipate those so that you can prevent the risk of recurrence by covering those areas. Today, contouring guidelines synthesize all of the most up-to-date understanding and protocols that have happened. And I think that these contouring guidelines should be used, especially when we're starting our 3D practice. Like I said, you want to start with your best foot forward and always practicing the best habits from the beginning. So our first guest website today is EContour.org. And I have a quick question. Okay, if you can answer questions 1 and 2, you should see on your computer screen or on your phone screen a poll. And if you can take the next 30 seconds or so to put in your answers on the poll, I'll wait for your responses. And once people have responded, I'll keep this going. So the first question is, before this lecture, were you aware of EContour.org? And the second question is, before this lecture, were you aware of I Treat Safely? Okay, let's give 20 more seconds. We have about 40 participants so far, so keep putting in the responses, please. Okay. 3, 2, 1. So before this lecture, we see that about 1/3 were aware of econtour.org, but 2/3 were not. And even less were aware of itreatsafely.org. And then it's nice you already answered question 3, but I really hope that after this lecture that you have this new awareness of self-learning resources that you can use to provide the best care that you can. So thank you for answering this. Here's econtour.org. You can see my screen okay?
Yes, I see EContour on your screen.
Okay. Great. So yeah, EContour was actually developed out of UC San Diego, where Tia is right now. But it's great. This is an amazing resource for contouring. You can create a free profile, and then once you're logged in, if you click cases, you can see, based on the Z site, what kind of case you might want to look at. And so let's say I wanted to look at a rectal cancer case. So there's no software you need to download. Everything is just free and on the website. And here you can see, what was the treatment. Here's some of the guidelines that are used. And here's some clinical pearls. And then here, we can see the OARs. So they had the bladder in yellow, the bowel, femoral heads, and the rectum. And for the targets, you can see which targets they are. So this shows you how to draw the contours for this specific kind of case. And I think it's amazing. They also include some of the normal anatomy, so you can tell what the different vessels are. The next website I want to show you is ProKnowsystems.com, and they have this quality contouring. And here you can draw something, you can practice, you can get feedback, and you can practice again, and you can see what your improvement is. And this just shows what the variability was in people's first attempt. And now after practicing, how they're able to improve their scores. This is 100%. So just using the link that is in the PowerPoint presentation, you can see that they have currently ways to practice for these structures. And I think they're working on developing more structures. And this I call man's best friend. So these are the NRG oncology contouring atlases. Follow this link here, and you can see atlases for these different disease sites. Very helpful for contouring. Let's say you want to look at head and neck. This will show you here the Gregor paper, which is available for free here. And then here is the atlas, which you can scroll through. And you can see how they contour all the different lymph node stations. It takes you slice by slice. And you can spend lots of time here, but it really provides everything you need for, at least for these lymph node stations. I use this a lot when I was learning my head and neck contouring. So this is very helpful, and they have it for other disease sites as well. Here are just some other resources. So there's itreatsafely.org, which has a library of different physics planning videos, simulation setup videos, a lot of diverse things which you might not be able to find on YouTube right now. You can find on iTreatSafely. Dosapedia.com is also a really nice website that has some great articles and some videos. For anatomy, I really like this sectionalanatomy.org. So you see the CT on the left, and then you can see a cartoon on the right. And if you want to know what something is, you just click on it. And then it shows you there on the bottom, that's pancreas, aorta, inferior cava. This is just bowel. You keep going. So very helpful, in particular when I'm doing my pancreatic cancer cases. But they also have other diseases. So they have head and neck, and they have a brain. So I'm sure everyone has their favorite website, but radiation. And then getting into exponential decay, brachytherapy, isotypes and sources, dose, half-life, basically like all the most important topics to know about for physics. These are just like really nice videos. They're maybe like 6 or 7 minutes long each, and you can just watch them for free. For kind of and hope you can benefit from that. Also, chartrounds.org is a website that I hope you're familiar with. Here, they've recently become international. So you can see if there's a chart rounds in your area, or if not, if you want to sneak into a different area, you can join these live sessions where they have experienced physicians talking about cases. And if you have a case that you want to share and ask for advice on how to treat it, you can do that during chart rounds. It's a very safe environment where everyone's just joining to learn. You can create a free profile here and then follow the instructions that they show you in order to attend the sessions. And then lastly, this is something called ROECSG, ROECSG, which stands for Radiation Oncology Education Committee Subgroup. Actually, I don't know what it stands for, but they have some great introductory videos, which I think especially helpful for new staff or for new residents. And they also have their own library of resources, which they want to share. So hopefully this RCC RADONC self-learning Excel sheet will help you to have access to all of these resources and to be able to use them however you wish to promote your own self-learning. I think some of you have had a chance already to look at this a little bit and tried to organize the websites with easy descriptions of what they are and also whether or not they're free. And if you know of other websites which you think are also really helpful or have helped you, feel free to let me know and I can add that to this list. So we put this all together. We've already had many lectures on physics. Now we're getting into contouring, and we'll be getting into planning as well in more depth later on, as well as covering the importance of our daily positioning. So it really is a team effort. Communication is vital as we're doing these different steps. And I really encourage you to implement documents and checklists to help you set the standards for your center. With RCC and ProKnow, I think we can really capture the success of the plans that we're making. We can share these and learn together and really improve as a team. So this is what I'm trying to do to help. I hope it can be helpful for everyone involved, and thank you very much.
Great, thank you, Ben. We do have a few questions from the audience. The first question is regarding the Quantec guidelines. If your local protocol is such that like each fraction is different from 2 gray per fraction, should you recalculate your endpoint values using the BED equation in order to compare with the Quantec guidelines?
If you read the paper that I've shown here, Introduction to Quantec, a user's guide, and also the use of the Quantec guide, how to think of it clinically. So these 2 links, they'll talk about this specific scenario. The Quantec it cautions you against doing that, particularly for hypofractionated regimens. So if you're doing something where you're doing more than 5 gray per fraction, really, I think the better thing to look at is the TG101 guidelines. This was a more recent report from the AAPM looking at hypofractionation dose limits for OARs for 1 fraction, 3 fraction, and 5 fraction treatments. For Quantec, I might use it as like a rule of thumb. You know, you can try to calculate the BED for something that is more dose per fraction than 2 or 1.8. It also depends on the alpha beta. And I think for Quantec, they use the alpha beta of 10 or 3, sort of depending on the organ. But that's also a limitation that we don't know exactly what the alpha beta is for all these organs. They're just estimates.
Great. I think that's very helpful. I think that definitely answers the question. Next question is, do you have a recommendation for an on-the-go book for target volume contouring?
I would say maybe on-the-go articles. So Nancy Lee has a really good collection of contouring articles. She has a book also, but I don't know if everyone has the book. But that's a great place to start. And Dr. Bistoon or anyone else, if you have trouble finding these contouring publications, let me know and I can help get those to you.
And is that Nancy Lee, L-E-E or L-I?
L-E-E. It's not my mom.
And that is all the questions that have been input already. Does anyone else have any questions?
Let's see. I see one private question that was written to me. Can we use the same username and password for 2 different computers for ProKnow? Yes, you can. You can't simultaneously be working on the same contour, but other than that, you can do everything else at the same time. I like reading your comments. Thank you so much. You know, I'm definitely not the smartest person out there, but I can do my best to try to share the best resources that I've found so that you can become smarter yourselves. Okay, well, it's late, so I hope everyone stays safe. Enjoy your time with your family and your friends. You're doing a great job with this course. I was really pleased with the cases that were uploaded. We're looking forward to the sessions this week and for the homework assignments to come.